This podcast is intended for informational purposes only and should not be interpreted to be direct medical or psychological advice for you or a specific individual. Always consult your personal physicians and clinicians for your individual medical and psychiatric care. The views, opinions, and information presented from any of our guests do not necessarily represent the views and opinions of the host of this podcast. We hope you enjoy this show.
Hello, I'm Dr. Jeffrey DeSarbo, a psychiatrist and eating disorder specialist.
And I'm Lukas DeSarbo, an LMSW, specializing in the treating of eating disorders.
And we want to welcome you to our first podcast here. Podcast, we're going to call it 101. Kind of that introductory course into what we intend to do. And it's today we're going to cover some topics on the effects of COVID with eating disorders over the past year with the pandemic. Now, our podcast is Translating Ed. We want to welcome you to this. It's where we try to take some of the recent scientific research on eating disorders published across national and international journals that are medical journals, psychology journals, neuroscience journals, all the medical specialties. And when we find these articles, we're trying to kind of translate them and take these often complex published articles and concepts and put them into a user-friendly form that we can discuss here and how it applies to patients, clinicians, families, and the treatment process itself. It's not always an easy thing to do, and always when we're translating some of these articles, you may hear terms that sound a little complex, and I would encourage everyone, don't get caught up on that. The only benefit I found some people is when you hear these things, it's like, I think it does help demonstrate the depth of the intricacies of the science that is related to eating disorders. Each episode that we're going to be doing, except for today, we're gonna kind of go over some of the most recent research that's been out anywhere from the past 3-4 months to now, to the most recent broadcast date. And we're going to be trying to do that, translate these articles and the eating disorder. A little bit about myself on our first podcast is, so I am a psychiatrist who specializes in the treating of eating disorders here on Long Island, New York. I kind of got into the field before I went into medical school. I was in a different line of work. I actually have a degree in banking and financing, and I wasn't thrilled with my course in life. So I kind of changed direction. I was married with 2 kids, and I remember telling my wife, I think I want to be a doctor. And fortunately, I have one of the most patient wives in the world. She said, well, do whatever makes you happy. And so I embarked on a course that really required about 10 years for me to go pre-med, medical school, residency training. And it was during that residency training that I got exposed to eating disorders as I trained at I trained through the New York University medical psychiatry medical training residency program. And 2 of my residency directors were specialists in the field of eating disorders. In fact, one of my residency director, Dr. Jack Katz, has an article that was published in the very first issue of the International Journal of Eating Disorders. And so I kind of had some mentors early on. And during my exposure in medical school, I had very little exposure to actually eating disorder treatment. But it was in my residency that I began having patients, and I began accepting patients that oftentimes other residents weren't so thrilled to take on that had eating disorders. And I found it to be a complex issue that somehow or another I seemed to feel comfortable and I understood. So it led to, after I finished my practice, I always wanted to be a private practitioner working with clinicians. And I kind of set up working with people who work with eating disorders. And that's how I kind of developed my practice. Along the way, as a psychiatrist, people always think, oh, so you're the people who prescribe the medication. And that is just a small part of what I do, psychopharmacology. I am very much involved in the process of therapy as well. In some patients, I work with the psychopharmacology, and the patients have their therapist. And there are a handful of patients that I am also their psychotherapist, and I do a lot of CBT, existential therapy, and other therapeutic approaches that might be appropriate based on what I feel the client needs at the time. So I've kind of evolved to this place now where I read a ton of articles and abstracts on the neuroscience and on the neurobiology of eating disorders, which has kind of developed into my specialty. On my YouTube channel, Dr. Jeffrey DeSarbo, I have a whole YouTube neuro series, like over 15 episodes as of right now, and probably more down the road, that talks about the neuroscience of eating disorders. And I encourage anyone who wants to really see a different side and perspective on eating disorders to check those videos out. So I have been in private practice, and then I started some eating disorder treatment programs under the name of ED 180, Eating Disorder 180, Eating Disorder Treatment Programs. And I work with multiple clinicians, therapists, nutritionists, speech and swallow therapists, and we're really, I feel, have done some great work with patients here on Long Island, New York. And I've also traveled nationally and internationally, both to lecture and to do consulting treatment. And that's kind of led now to us kind of putting up a podcast, because who I'm going to introduce next is my son, Lukas DeSarbo. So it is something that I guess now is turning into somewhat of a family business. Although I say it's not. We're only I'm generation 1. He's generation 2 in this field. But fortunately, or however Luke perceives it, he grew up with me around all the time. Like, even, like I said, I went back to medical school when he was a little boy, and he's always seen me studying. He's always seen models of the brain around the house. I don't know if you remember, Luke, but you and your sister would go through my anatomy books, seeing the most gross dissections and I think we even have a picture at some point of myself doing a dissection for an anatomy class on a female pig. Yeah. And Lucas and my daughter, who's a couple of years older, were actually there with me, totally fascinated by the process.
So yeah, I was about 3 at that time. So.
Yeah. So I'm really proud to be here with my son Lucas, and he's going to tell you a little bit about himself. And Lucas is a therapist who has some experience for quite a while now, actually, being around eating disorders, working with eating disorder patients, and being also, because of what I do, I think kind of without choice, exposed to a lot of the neurobiology and neuroscience, which I think he's been doing a great job incorporating into therapy. And that's part of my process. The type of information I share here, I want families to understand. I want patients to understand. But I really want clinicians to understand. And talking about some of these research papers and stuff is the type of things that any good clinician, I hope, is constantly looking and doing database researches on eating disorder. We're just going to provide a snippet of that each week. So Lucas, why don't you give your explanation of how you got here?
Okay. So, yeah, I think when I was about the age of 10, you were finished with your residency. And as I was getting a little bit older, I remember I had a job in a restaurant at a time, and I was looking to earn a little bit more money. And at the time, you were actually starting to put out your first, attempt at a web series where you would interview clinical directors and providers from around the country. And you were just like, oh, here's a little side job. Like, why don't you take these hour-long interviews and break them down into like 10 or 15 minutes worth of like good content to put on YouTube? So, and at this time I had no idea I would end up in this field. At the time I was actually planning on a career in music, kind of like how you were planning on a career in banking and finance. Right. So apple doesn't fall too far. But So, when I was breaking down those interviews, my job was to take the most important information from those interviews and put them in a way that I think people could understand. Being a 16-year-old at the time who, kind of knew how YouTube worked, so I knew what parts to look for. And then so basically at the age of 16, I was getting, I want to say I was getting virtual supervision from clinical directors from the best treatment centers around the country. So that's how I was first exposed. And through doing that, I started to become just like subliminally familiar with that language. I kind of understood it, and I was growing a better understanding of it without even trying to.
Right.
And then after that, you started beginning your Long Island Conference on Eating Disorders, where a lot of these providers would come from around the country to Long Island and conduct about an 8-hour seminar at
Conference, conference with multiple speakers,
Yeah, so and my job for that was to tech it. So I was making people up, and I was sitting there watching all of this, just taking it all in, listening mostly for the mics, but how could I not absorb some of that information? And that was when I was about 17, 18, and then around the age of 19, I actually switched my major from music to psychology, just because I had an interest in psychology, not even necessarily eating disorders at the time. And then I started working for 8180 as a biofeedback technician. So I trained for a few days on how to use this newer kind of technology, and I was maybe I can save the explanation on what biofeedback therapy is for another session.
But it was a big, nice biofeedback unit.
Yeah.
And Lucas, he was working exclusively with the eating disorder patients, and those in the field know it's hard to have the right personality. And all the people in my office, because we have multiple therapists and everything, I would get great feedback. And that the patients really related well. Luke, he knows the lingo. He learned it early on. What do you say? What don't you say?
Exactly. and just the idea of making them feel comfortable in that kind of space to do that kind of exercise. And as I was working that position, I would have the treatment providers, either nutritionists or the therapists, come to me and ask how the session went. And I would tell them, not even knowing that was my first experience with collaborative care.
Right.
So moving on, I got my degree in psychology from LIU, and then I went to Stony Brook for a master's in social work. Briefly before my license, I was working for a treatment center as a recovery coach. So I was, having meals with clients who needed a higher level of care, who needed residential treatment. I got to know what their days kind of looked like, what their struggles looked like throughout their day, which has helped me immensely as a therapist to just get to know this client base at a personal level and see how they function, how they interact, how they relate. And then fast forward to today,
Right.
I've been working in the practice under 8180 treatment programs with you, with Siobhan Cohen, with our nutritionist team, and with many great treatment providers.
And Luke, also, one of the things that's unique is it's often hard to find. We would get a lot of calls at times, and we still do, with younger and younger patients with eating disorders. Sometimes the calls are as young as 6, 7, 8. Which, usually is very difficult to treat. But, we do get frequent calls with people who are 10, 11, 12, 13, 14. And Luke has, developed a great ability to establish rapport with younger people and work with them, because it's so difficult to work with children, adolescents, and teenagers. But Luke had a lot of experience. I thought he was going to work at what was the camp? Cornell Cooperative Extension?
Yeah,
4-H camp. And I think he loved that so much. And working, first going to the camp, being what's your first, eventually becoming a counselor, and then...
Yeah, and then a counselor, and then I was the music director, and I was the sports director, and then I was basically an assistant director.
And I think that brought something really... Actually, I thought I might as well just have him go into the camp business. But but I think that exposure gave him some really different types of experience to be able to work effectively with the younger populations as well, which is hard to find these days, and I'm happy to have him on. So, what's that?
No, I just need
a pen. Okay. So we created this podcast again to do that thing and translate what's going on with the research that's out there. That it's complex. We want to make people know what's going on, what type of research is going on, kind of understand it, and to provide an education to the patients, to the families, to the clinicians, in a hope that they can use it in treatment, use it to strengthen themselves, feel better about themselves. And this, our approach is always something that's a little bit unique that you won't typically read in most eating disorder books or find at most eating disorder talks or what's presented on TV. So hopefully you're going to get something a little different. And I think we'll get started just talking a little bit because, again, usually we're going to have a guest on most of our episodes, but because it's our introductory video, I'm just going to go over some studies here that have been out recently, because here we are starting this podcast in where are we? Like May of 2021, and we've been through a year with the COVID-19 pandemic and everything, which has had a great influence on everybody throughout the world, but especially we look at for ourselves the impact it's had on our patients and the eating disorder population. So just to go through just briefly, summarizing these different types of studies have been published in the journals. Like here's one, International Journal of Eating Disorder of 2020 in November, the impact of COVID-19 on eating disorder patients. Essentially, these studies have shown things like patients have had with like anorexia, increased urges to exercise. Bulimia nervosa patients have had, of course, exacerbation in their symptoms with binge eating. The lockdown has interfered with treatment outcomes, and this has all been researched and everything. And it's previously remitted patients who have kind of been doing well with their treatment, kind of go into those recovery pages, have kind of been relapsing. One of the things that was also found was household arguments and the fear for the safety of loved ones in this study here often predicted an increase in symptoms during the lockdown. So, people were often more concerned about family members and a lot of than they are with themselves. And they found in the study that patients with bulimia nervosa reported more severe COVID-19 related post-traumatic stress symptomology than even patients with anorexia nervosa and healthy controls. And that people, especially individuals who may have had a history of early trauma or insecure attachments, were particularly vulnerable over this past year. Other studies have shown, there's a study out of the UK published in the Journal of Appetite in 2021 of April, just showed that women were more likely than men actually to report increased struggles with regulating eating, preoccupation with food, and especially struggling with body image. There's so there's a lot going on. Just you've seen that in your patients too?
Yeah, absolutely. The isolation it's I feel like it is a combination of two things. It's the uncertainty factors, like you were saying before, which for any clinicians listening, when it comes to safety and control and certainty, you can just go back to Maslow. We need certainty to feel safe sometimes. So you will see a reaction in times like those as you would see in most anxious responses. But as far as the isolation goes, I hear from parents, even some of the clients that I'm getting now, this all started sometime back in April. This all started sometimes back last May in 2020, because the isolation, it exposes the potential for an eating disorder in a way that somebody might start deciding that they need to do something with themselves. They need more structure. What can I do to improve myself? I mean, you see it. You can see it all over the internet. This was my COVID project. This was my pandemic project. I made a garden box. I redid and for a lot of people, it was I'm going to work on myself. Right. The more hyper-focused they become on that, the more predisposed they may become.
Although that's one of the things, I have a study here that over 500 people from the U.S. and 500 people from the Netherlands were studied during COVID. And again, some common things you might even expect: participants reported increased restrictions. They had more fears about being able to actually find foods that are consistent with their meal plan, especially in that beginning where people were worried about food shortages and stuff with the pandemic. And it's like, but I have certain safe foods, and people got nervous about that. With bulimia nervosa, there was increased binge episodes, increased urges again. That's reported in this study. Significantly increased anxiety, greater reported concerns. They worried more that COVID-19, actually, people with eating disorders, was going to affect their mental health more than their physical health. And on an encouraging note, people who responded to all these surveys, this over 1,000 patients here, reported positive effects with greater connection with family members, more time for individual self-care, and motivation to recover. And what we saw is, because there was all this downtime for so long, people did say, I've got to address this eating disorder. So people were more willing to go into treatment for it, and residential facilities often filled right up. And both were having patients that we felt needed treatment. And probably by August, it was difficult to get patients into the proper level of care. With 6, 8, 12-week waiting periods, which can be very hard if someone's struggling with an eating disorder. So yeah, for the next study, we were looking at something from the Front Psychology Journal, published in October of last year. Being my own companion in times of social isolation, a 14-day mobile self-compassion intervention, improves stress levels and eating behavior. In this study, we were looking at the maintenance of healthy eating behavior, and might it be an additional challenge? And really what they were looking for is, self-compassion's effect on eating disorder treatment outcomes. Right, and if you offered a program, what they did is, and the study was out of Austria, actually. That's the interesting thing about a lot of these studies, is they're done in a lot of different countries, so the research has been expanding over the years. So what they did is, there were 65 participants. They split them in two groups. There was it was a randomized split. They had a 14-day compassion intervention arm, and then they had an arm which was the control arm, which was, they just put people on a waiting list, so they really weren't having any treatment at the time. And they took a questionnaire both before this 2-week period and after this 2-week period. And the questionnaires were on self-compassion, eating, dieting, health behaviors, emotional regulation, and they found that essentially in the treatment arm, those who had that, what they offered for treatment was journaling, meditation, and smartphone. Decrease in smartphone use. Right. Yeah. But they used the smartphone for the meditations and everything, all with a focus on improving eating behaviors. And again, the study kind of showed that just even getting this type of support, there was changes in self-compassion that fully were mediated and regulated the changes in stress levels. Meanwhile, in the group that was the control group waiting, who didn't get this journalizing and meditation through smartphones and that type of support, there were no changes. They still had high stress levels. And so I asked, like self-compassion might help actually be something, according to this study, that maintains well-being and healthy eating habits in times of increased stress. And I think the only thing is, we got to kind of, do more studies on. This is a good study to replicate to test the effect of self-compassion in samples with eating disorders. The other study I have here, Luke, that we were going through was an audit was carried out to explore lockdown periods and impacts on referrals and the delivery of service for patients with eating disorders. And they took this quantitative data, had 43 participants, including patients, parents, caregivers, and staff members. what they really kind of found was there was this increased pressure on places, on the service and the service changes that were significant. And patients and caregivers and staff all seem to prefer these face-to-face appointments over virtual options. However, there was really no overall difference reported in satisfaction, although here I pull up another study that's in the Journal of Eating Disorders in March of 2021. The abrupt transition from face-to-face to online treatment for eating disorders during COVID-19. And what was interesting in all of this in the end was they found that there's mixed views were found regarding the transition, with the majority, 68% of people, actually said they would not choose to continue online therapy given the option for their treatment. Wondering what you think of that.
I don't find it too surprising. I mean, I feel, the connection is such a big part of feeling comfortable enough to explore a lot of the issues, not even the ones that are at face value, but the underlying ones, being able to make that connection and go one deeper. And I feel a lot of clinicians were definitely taken back to the possibility of having to make this abrupt change themselves. So,
although it seems they've adjusted, that's what I found interesting. Is, if you look at this study that was just published, it's kind of like saying patients, 68% of them would rather be back in treatment with face-to-face. What I've seen working with so many people now is clinicians seem to have found it more comfortable to not go in the office, and they almost prefer the online. A lot of rules and regulations are going to change again when COVID kind of gets more under control. Hopefully it will. And the clinicians, I think, want to stay at home. Too many, and are not getting back in the office, which is really something patients seem to prefer. And who knows how that will ultimately, if you test out the results, come up. And finally for today, we have a few minutes. Okay. Finally for today, I wanted to discuss something that Lukas and I started working on early when COVID kind of came out. This was really in the very beginning in the United States when it started making its full rise. I'm going to say it was the month of March when there were so many unanswered questions. There was a lot of fear out there. Both of us living in New York, which was hit so hard, we really felt the lethality of this new virus that's out there. And in the treatment field, there was a lot of discrepancy of how do we handle treatment at that early point. So I wrote an article that Lukas helped with the research and the organization and everything with, called Anorexia Nervosa and COVID-19. The article's been published in Current Psychiatry. I think it was the August issue. However, we still have to get it up on like PubMed and Medscape and stuff. Where
work in progress.
We're somehow responsible for that, and between his ADHD and my ADHD, we hate paperwork and doing those things. So.
That's why, but we do have a lot of variety as a result of that.
Right.
So there's a silver lining.
That article is available on Medscape for any clinicians who have access to that. And if anybody would like a copy of the article, you could also email me at drdesarbo@gmail.com. That's DRDESARBO@gmail.com. So just to cover some of the stuff we uncovered during this research, a lot of the research right now that is available in the internet databases on COVID and eating disorders tends to talk about the types of things we had, with how it's affected quality of care and everything. This article right here, I really got into evidence-based concerns for infection, detection, immune function, malnutrition, and treatment with eating disorders, especially anorexia and nervosa. And I was hoping at this time, because I was getting a lot of mixed messages from different clinicians, although at that time we were all getting mixed messages as to what to anticipate from this. But there had been some conceptions. Some people have said to me, I don't think we have to worry too much. People with eating disorders actually have lower rates. And I remember being stunned when I was informed, there's articles out there that shows people with anorexia nervosa are actually resistant to viral infections. And it wasn't making sense to me, but I know better than to just rely on that face validity, as they call it, just what makes common sense. So I went in and started doing the research and pulled up so much information. Our article had, I think, 52 references in it. So I'm just going to go over some brief stuff and everything that we came up with. I think the common conception is, well, if someone has anorexia nervosa, there's that malnutrition component. They're more likely to get sick. They're more likely to have complications from this disorder. Now, the initial concept with many clinicians and physicians that, well, no, the data and the research kind of shows that people with anorexia nervosa are resistant to infection came from a few interesting sources. There was an article published in 1981 in the American Journal of Clinical Nutrition, which actually studied 9 patients, and it concluded based on that patients with anorexia nervosa have, quote unquote, resistance to infections, which was suggested that anorexia nervosa was a protective factor of the immune system. Now, what happened is this 1981 article that only consisted of 9 patients started getting referenced in other articles on infection and eating disorders and anorexia nervosa, several different articles. Now, when a clinician often keeps encountering the same article and reference point, it starts to become a accepted belief system. Well, I've read that several times in several different articles, even though it comes from one source that consisted of 9 patients. Now, out there are some other studies, that shows that there's no statistical difference that concludes the rate of infection with anorexia is higher or lower than the general population, and a lot of studies have shown that. However, sometimes some of the studies show that if anorexia is very severe, if you're talking at BMIs that get down into like the 8-9 range area, mortality, death from infections can be significantly higher. But again, there's no increase when you look at the data itself. It kind of shows there's no necessary increased predisposition to infection. And then there's some other studies that look at some of the details of that. There was a study of it was close to 1,600 patients that came out of eating disorder unit of Helsinki. And this was data they looked at between 2000 and 2010, and they compared it to over 6,000 matched controls. So you got 1,600 eating disorder patients, 6,000 matched controls, and they looked at prescription data of patients with eating disorders who received antibacterials, antifungals, antiviral medications. And they used that as an indirect measure of infection rates, and it showed that patients with binge eating disorder, bulimia nervosa, and anorexia nervosa cis males often received more antimicrobial medication prescriptions, while there was no statistical difference with anorexia nervosa females. And so the data was consistent with reports that, again, there's no increase or decrease risk of infection, especially with anorexia nervosa in females. But again, with specifics to antiviral use, the study showed that there was an increase of prescription of antivirals with the bulimia nervosa group. So once again, it's an indirect study to look, but that data is supporting no necessarily increased risk of developing infection because of someone having anorexia nervosa. Now, there's also another study done where they propose that patients with anorexia may show lower rates of symptomatic viral infections, but what they found is there's higher rates of asymptomatic infection in these studies where they looked for viral titers. So they didn't seem to have the physical symptomology of the illness in presentation, but their viral titers in their blood show that they have the infection. But the controversy over these infection rates and increased mortality and morbidity continuously get reported. Now, there's also this thing with eating disorders. There's features such as you can get an increased loss of adipose tissue, fat, okay? And fat makes so many hormones, and really plays a big role in your immune system. It creates these pro-inflammatory cytokines, these molecules that kind of send signals to others in the immune system of how to fight infections. And when you lose tissues like that, it can contribute to some of the complications possibly. It moderates the experience of the illness that can impact the core features of a disease. So when your cytokines aren't functioning right or everything, there can be a problem. It reduces that symptomatic presentation. Now, there was another study of 311 patients that came out of Australia that were admitted to inpatient units. And what was interesting in this study with infections is they found that people with anorexia nervosa demonstrate a significantly decreased response with fevers. So it's kind of a delayed response. And actually, the majority of patients looked at actually had no fever response. And if we remember early on when we're trying to screen or look for patients with COVID-19, fever was a hot topic. You have a fever, it's really something to look at. Patients with anorexia nervosa, again, don't seem to report a fever. So it was often used as a screening tool for like residential facilities and things like that, but probably wasn't a very effective one. So avoiding that detection early on may have been a problem. Again, I'm not going to get into all the details, but symptoms of anorexia nervosa often can mimic or look like what people with COVID were coming down with. And if you have clinicians writing off, well, you have cold intolerance, you have flu-like symptoms, you don't have a fever, you can even have shortness of breath because anorexia can cause something called nutritional emphysema. You can get respiratory muscle weakness, so people could be coughing. But they write that off to the anorexia nervosa, and cases of infections like a COVID-19 easily could be missed, and that was something we wrote about. Won't get into too much of the medical details, but even lab values, like people with anorexia nervosa tend to show kind of across the board low white blood cells, low counts with the specific types of white blood cells. I will say that kind of like there's a lot of information I could go over here, and it's all in this thing here. It affects different types of cell immunity, which is natural cells in your body, your killer T cells, and CD8 killer T cells and things like that. Humoral immunity is your antibody response, which is what we're trying to do with vaccinations and everything like that. Actually, people, one of the things that's interesting is those cytokines, which seem to be affected in people with eating disorders. Those are the chemical messenger signaling proteins, and they're responsible for things like fever. In fact, sometimes people are worried, well, if you get a vaccine, especially a live vaccine, it can create this cytokine storm. People get really sick. People who get fever, muscle aches, pains, even with the current COVID-19 vaccines, it's because of the cytokines. It's really your immune system working that causes cytokines are supposed to cause a fever because it makes the virus harder to live within you. Again, our article has a lot on the immunological effects of COVID-19 compared to with anorexia nervosa. One final point that I really want to make is they looked at that question. So if someone's malnutrition, it seems to make sense that their immune system might be compromised. But what they found is there's a difference in the type of malnutrition with low-weight anorexia compared to the more common protein energy malnutrition. And this might explain why patients with anorexia nervosa maintain a relatively intact cell-mediated immune system. Protein, the PMM, the protein energy malnutrition, is found in typical cases of like starvation, which is you have deficiencies in multiple vitamins, proteins, and especially energy, caloric restriction. Whereas dietary habits with anorexia nervosa usually results with deficiencies in carbohydrates and fats. And we can get into this whole explanation, but it's interesting because carbohydrates are the primary nutrients for human bone marrow. in the fat cells of these bone marrows, which play this crucial role in your white blood cells maturing and working and functioning properly. So there's conflicting data with impairments in the immune system and everything, but some people say the immune system with anorexia nervosa is not working. Some people say it's just dysfunctional. And other people say it looks to be working relatively well. And I think there may be a component of that is where are you with your anorexia nervosa? Are you at a BMI of 17, a BMI of 12, a BMI of 8? That can make the big difference. CDC and WHO, of course, doesn't say what the guidelines are for treating COVID-19 with an eating disorder. So basically, our advice has always been just listen to the CDC, follow the WHO guidelines. Don't keep surveillance high. No fever doesn't mean anything. Asymptomatic doesn't mean anything. Now, on a personal note, I have had several patients with eating disorders who have developed COVID-19, and many have been asymptomatic. A few have been hospitalized. I also talk with clinicians throughout the world. I have had a person with anorexia nervosa from another clinician who has died from COVID-19. So it definitely does affect the population, but most likely the risks are about the same as general population. So it's something to still take the necessary precautions with and everything, and to talk to your doctor about. Make sure they know what's going on with you. Always, I'm going to say, when you have an eating disorder, tell your physicians what's going on. So that kind of summarizes our paper. We do have, I recorded some of the summary on a video, which is also on my YouTube page, Dr. Jeffrey DeSarbo, which kind of is a nice YouTube video presentation, some nice slides, and then I had a follow-up to that as well. So if you're more interested in anorexia nervosa and COVID-19, please check that out on Dr. Jeffrey DeSarbo on YouTube. So, Luke, I thank you for joining me in this podcast, Translating Ed, and we'll be looking forward to our next episode, episode 102, where we'll also have as a guest Robin Goldberg, who's a very experienced nutritionist who specializes in eating disorder treatment in Beverly Hills, California, and she wrote the recent book, The Eating Disorder Trap. And look forward to seeing you on our next podcast.